I'm just realizing again. 20 years ago, I was already doing interosseous release in those cases. So that's the place of the interosseous. If you want to find the interosseous ligament, just with a small incision, you go up to the olecranon here, you get up down to the styloid process, and you go halfway, and from halfway and distally, you find this from 2 to 3 centimeter length ligament. Here you see during surgery. This is not that specific case, it's another one. I just combine 2 cases to show the surgical approach is halfway glioma and distal. So you put 2 small Oman retractors like this. When you stick here inside the scalpel blade and you release, you go deep with 2 to 3 millimeter inside. If you go deeper than 2 to 3 millimeters, sometimes you get some veins, so you see some bleeding. There are no arteries over here, so it's not that dangerous. You just incise the ligament, and it's not a ligament as one would expect ligament, like a little piece of cord. This is a much wider and much longer. So is and thicker. So you just incise the ligament. As soon as you incise the ligament, those Oman, they pop out from they do. That means you got the release. Then you stick inside the periosteal elevator. You rotate the periosteal elevator, and you see the 2 bones moving apart each other. And with a small gel clip, just opening here. Extensor muscles. That's the arthroscopy. I think that's just the picture where you see here. That's the coronoid, part of the coronoid process. Here is cranial, here is caudal. This is the trochlea, so the medial aspect of the humeral condyle. And so the head of the radius was covered by blood and was distal to the level of the coronoid, more or less the same amount that we measure during surgery. It's not that much, it's less than this because when there's some discrepancy, in my experience, you have a thicker cartilage, so arthroscopically you lift the cartilage at the level, but then radiographically the subchondral bone looks like it's more distal because we have a thicker cartilage than in a normal bone. Because maybe there's no weight bearing and the cartilage is going to be thicker. I don't know, but it's not. They don't match all the time. But when we do the lengthening arthroscopically guided, we want to match the cartilage because it's the surface that is gonna go weight bearing. This is one of the distractors that I have that comes from the human medicine. It's called Castaman, and it's just an X-fix. In this case, I put 2-3 millimeter threaded pins proximally to distally, and then I lengthen, moving this proximally. So when I did the lengthening, it was done before cutting the ulna. Then the lengthening was made from the pins. They go from cranial to caudal, and then the plate. I think the plate here was on the lateral surface of the radius. So you apply the plate, and then after applying the plate, you remove the X-fix, and then you're going to cut the ulna distally. You're going to fill with bone graft coming from the same ulna, and it's going to be autologous bone graft. Here you see after lengthening. This thing here is this one. And after lengthening, the head of the radius is at the same level as the coronoid process, what remains of the coronoid process, because the tip of the coronoid process is missing.
Sorry, Massimo.
Yeah.
When you're lengthening radius, how are you positioning the scope? As you mentioned before that you would do these cases on sternum.
How I do position the scope?
No, so you mentioned before that when you do the corrective osteotomy, or in that case where you have the open approach to lengthen the radius, you mentioned earlier this morning that you would position them on sternal recumbency, but when you're trying to scope them concurrently.
Oh, yeah, you're right. That not all the cases are the same. In these cases where you do the lengthening, you need the dog in lateral recumbency first, do the scope, and then I think we just move the dog this way, tilting the bed. Yeah. As I mentioned this morning, earlier this morning, there are many rules, but then you need to adapt to specific necessity. When you do arthroscopy, I don't think we have never done arthroscopy and then moving the dog from dorsal or lateral to sternal, because it's really difficult. That would be another procedure, and you don't want to move, because we do arthroscopy first, we check, we remove the coronoid, then we do the osteotomy, the lengthening, and then while we think we are at the end of the lengthening, we put the scope back again and we check the final adjustments. So we have an estimation to lengthen 8 millimeters, we lengthen maybe 7.5, something as this, and then we check with the scope at the end. So that's a good point. I don't think this was the case, but in the case you don't need the arthroscopy because you don't have to lengthen or shorten, and you just do the correction of the distal aspect, just the distal valgus or procurvatum, then the sternal recumbency is the easiest and the more comfortable.
Thank you.
You're very welcome. Here you see that after the lengthening, here one in the AP view, it looks like we are in a good shape, maybe. But in the medial lateral view, see that the head of the radius is over here. There's some room there, but cartilage-wise, the two ribs and ulna, they were level. What does it mean? That the cartilage is thicker than what is supposed to be. Otherwise, we would see also the cartilage distal to the left. But as long as you see this after you check with the arthroscopy, and you saw already that we're at the same level, it's fine. And also you're going to see the dog walking back. Here's the piece that I removed from the distal ulna. I put it back here in the proximal radius. Those are the holes for the lengthening. And here you see maybe this is 1 centimeter. So the osteotomy was 1 centimeter from those are 3.0 millimeter screws. So this is more or less 3 times the diameter of the screw. So it's about 1 centimeter, maybe a little bit more from the joint to here. And the screws are midway, the osteotomy and the joint. And I just put 2 screws. Nowadays I would put 3, maybe 3 or 4, according to how the bone is hard perceived with the osteotomy, and also while drilling the bone with the screws. A T-plate, dorsal. In this case that was an L plate. Nowadays I would use a T-plate, and here it was a straight plate on the, that's the medial aspect of the, I said there was the lateral, but it's the medial side of the ribs. It could have been also on the lateral side, both they work nicely. Then we check the alignment, see the preoperative valgus. Then we went to a more natural few degrees of valgus. I think we corrected a little bit of a torsion. You see now the hand is in a more true AP view, and also here there was an oblique view, and here is what we would expect, 1.5 more or less the size of the base of the metacarpals. We got from this procurvatum to this, which is normal, so I was happy overall. Please.
And could I choose and fix the deformity distally and cut more ulnar and lose the internal safety and to then dimensioning to compare the elbow joint later?
Here, I don't think in this specific case, I'm not sure I release the interosseous ligament. He said that the previous picture is not related to this. I put the picture to show you how to do the surgical approach for the interosseous. But if you want to lengthen a bone, a radius, you need to get the. Now in this case, I don't remember.
In this case, can I choose shorten
The ulna instead of lengthening radius? Yeah, you could. You should. You could, not should. In this case, shortening, actually, here we did it. The ulna also was dynamically shortened, right? So we did it. In the case you have maybe 2 millimeters, 2 to 3 millimeters, I think it's going to work. With 8 millimeters, I'm not sure. So it's a good point. It's going to be much less invasive, just doing ulna short here. I don't think in my hands worked with 8 millimeter in a 20 kilo dog, because it's quite significant. But in the case it was 2-3 millimeters, I would do just the ulna shortening distally with the interosseous ligament release in this case, because I need the ulna dropping down. And this is the one of the 3,000 more that I've done just for a small amount of incongruency at the level of the elbow. So distal ulnar ostectomy, morcellizing, getting the bone back and releasing the interosseous. Here I didn't morcellize anything because I needed the bone graft to get it here. So I just removed a piece of bone, maybe 8 millimeter length, and I transferred the bone, the whole bone, not morcellized, as a bone graft there. But because it was coming from the epiphysis, it is a healing machine over there, because it's cancellous bone. But I don't remember every detail of every specific case, but I can say what I would do now, I would do today, or what I'm doing today. This is the same dog 12 weeks later. You see that it was very close to being indistinguishable from normal. It wasn't limping anymore. And the bone graft got almost nicely healed. There's still some lucency. The distal radius got healed, and because it was a 6-month-old dog, also the ulna recovered with no big issues. This is my friend Ken Brooker. Came visiting, and we did the opposite way around, the ulna lengthening in this case. You see that in this case we see an ulna that is too short. There were no deformities on the frontal plane, and I consider this as acceptable as deformity. So I didn't touch the radius has a procurvatum, but the ulna was not in the right shape. You see that this ulna here is shorter than the radius. So here you could ask the opposite. Could we shorten the radius instead of lengthening the ulna? I don't think so, because it's dangerous, because the weight bearing is on the radius. So we leave the radius intact and we lengthen the ulna. If you see before the surgery, this is the notch here up to there, and after the surgery is matching with the radius. And that's the follow-up, I think 8 weeks follow-up, still matching nicely and with bone healing. Even here, I think I think this is a Z-shape osteotomy. I'm going to show you what a Z-shape, and we use the distractor, same distractor here. Yeah, the Z-shape is this osteotomy. It's like a tube. It's a Z. So you make a transverse osteotomy, a longitudinal osteotomy, and another transverse osteotomy. So when you do the lengthening, only half of the bone, half of the side is missing some bone. So you're going to slide one over the other, and then you put a plate and some screws. Here is the before lengthening and the after lengthening. This is the coronoid process, and that's the radius, the level of the radius. And the coronoid process is down there, the opposite way around as before. After the lengthening, you see that they are at the same level. So the radius was earlier here, and the radius, the coronoid process over there. This is some bleeding, and here after lengthening, they are level to the same height. And here's the technical surgical technique with the Z shape, the lengthening, and then you can apply the blade on the caudal aspect or on the lateral. It doesn't really make any big difference. So this is how it works. You do the lengthening this way, you cut the bone. You need a very thin osteotomy blade, 0.4, 0.5 millimeter. You don't want to remove too much bone. You cut the bone in this way, you lengthen, you get these two spaces. They're going to be filled by bone graft. You can grab the bone graft from on the proximal humerus, from the proximal tibia, or even though you don't put any bone graft in this case because you have a bone column, according to Wolff's laws, they're going to fill up very quickly. And then you apply the screws, and as the last thing, you're going to put some bone graft in there.
Massimo,
Yes.
if the product of trauma causing anconeal process fracture, do you recommend to fix the anconeal process?
In my experience, some of this anconeal, non-united anconeal, right? They're not fractured, they're non-united. Those are young dogs.
Because you said that sometimes shortening of the ulna can push the humeral to
The radius into the humerus.
right into
Yes.
the anconeal process and causes some fracture. Right?
No, those are not fractures, are non-unions.
Or is it really
So the anconeal process has its own growth plate, let's say, is an ossification center.
okay.
So if during the growing, especially in German Shepherd, Great Dane, Irish Wolfhound, Basset Hounds, during the growing period, the radius is longer than the ulna. The radius is pushing into the humerus, that is pushes into the anconeal process, that not allowing the fusion of the anconeal process. So you see it as a fracture with the radiograph, but technically it's not something that got fractured, it's something that never united with the rest of the ulna. And in my experience, sometimes is relative to this length discrepancy sometimes is secondary to torsion within the humerus. And I'll show you after this presentation. I'm going to show you one biapical, more challenging deformity with a humerus deformity to correct. So the humerus is, I think, only just underestimated as deformity. Okay, back to the game. I have a trick here for you. How to assess torsion using the fluoroscopy. We, in this case, not sure in which recumbency this dog was. Let's pretend it was in a sternal recumbency, but could be also in a dorsal recumbency. You get the fluoro, and you position the elbow as in a true AP view with the fluoro. And you hold the limb yourself. You're going to take some x-rays. But so you're going to cover with the lid, gown, and all the things before. And then holding the elbow in a true AP view projection, you move the fluoro distally and you check if the distal aspect is in a true AP view. If they match AP view with AP view, being a fluoro or a radiograph doesn't really change. That's no torsion. So that's a double check during surgery to make it sure you get the right alignment, torsion wise. As for, so we have here a take-home message which says that radiographs show bone, not cartilage. This can mislead surgical planning. So if you do lengthening just using the fluoro or using the radiographs, maybe you're going to end up in a lengthening that could be maybe too much, because if this radius is short, the cartilage is thicker than expected. Arthroscopy offers accurate joint visualization during bone lengthening. It helps detect hidden lesions like cartilage defects and fissures. We have practical benefits of arthroscopic guidance. And the last thing says arthroscopy improves diagnosis, precision, and overall outcomes. The other thing I have to say about arthroscopy during lengthening is that during arthroscopy, we usually put something, a leverage underneath the elbow, so the elbow on the medial side open up a little bit to stretch a little bit the medial collateral ligament and to get a easier approach. This especially in dogs smaller than 20 kilograms, where the 2.4 scope is not going really easily without opening a little bit. But when you're doing this lengthening or arthroscopically guided, better not to stretch the joint, because you're gonna add some, how to say, you're gonna change the angles. So maybe the evaluation of the two surfaces, this is not going to be so precise. So you can do stretching on the medial compartment while doing inspection, the fragment removal, but then better you go to neutral position while doing the lengthening, because I think it's going to be more accurate and precise. Okay, how many participants we have? I hope you're gonna get 30, 35 orders for the scope, for the columns now today. This is what I would expect. Otherwise I failed, and I'm not a good teacher. So back to the game here. We're gonna cover now biepical, deformity correction, and the humerus and the anconeal. So you were just one step ahead on the program. That's super cool. Let me find my mouse here again. Okay, this is 3 lecture at a time. One is an extreme surgery. 2 is a surgery on a humerus. 3 is a biepical correction, and we have also a 4 that is the longitudinal splitting technique. I was asked, how do you manage cartilage erosion on the medial side? When do you expect cartilage erosion? At 1 year old, 6 year old, 12 years old? When do you expect, in your experience or practice,